Thank you very much for inviting me to give this talk on aging with HIV. And today I'll focus on cardiovascular and bone health. So these are my disclosure. With access to effective and durable antiretroviral therapy, we are able to witness a near normal life expectancy in most people living with HIV. In all regions of the world, we are observing an increase in number of older adults living and aging with HIV, as shown in the diagram here. And not surprisingly, as our patients are aging, we will be expecting to see ourselves managing many of their age-related health conditions. As shown in this study, we can see that in those in the older age group, we can see a higher prevalence of various conditions such as dyslipidemia, hypertension, diabetes, kidney, and also heart diseases. In multiple observational studies across different parts of the world, we do observe a phenomenon of accelerated or accentuated aging in people living with HIV. So one way of looking at this is to compare the number of age-related comorbidities in people with and without HIV infection. For example, from this study in northern Italy, if we look at the people with HIV in this age group, 50 to 60, you can see that the bar look pretty similar to uninfected controls who are like 10 years older, meaning that people with HIV infection actually age earlier than people without the infection. And this applied to many of the comorbidities, for example, kidney disease, diabetes, hypertension, etc. And in today's talk, we will focus on cardiovascular disease and bone health. So as from this study from the Tahoe cohort, we can see that the burden of cardiovascular disease in people living with HIV is quite high. So in this study, following up more than 8,000 patients from Asia with a median follow-up of more than 7 years, the cardiovascular disease was one of the most common cause of non-AIDS-related causes of death. And you can see that the cardiovascular disease-related death was 0.36 per 1,000 person years, while cardiovascular disease events was more than 2 per 1,000 person years. And in this study, we observed that an older age, earlier period of antiretroviral therapy initiation, and some of these traditional cardiovascular risk factors do predispose patients to risk of cardiovascular diseases. So, do people with HIV have a higher risk of myocardial infarction than the uninfected general population? Well, there are actually multiple studies in the last decade from different parts of the world showing that people with HIV infection do have a higher risk of acute myocardial infarction. And if we look at the different age groups, in most of the age groups, we do see a higher risk in people living with HIV, as shown in the blue bars in this diagram. And you can see that the differences in myocardial infarction actually begins in younger populations. Likewise, in this recent study published from China, looking at carotid intermediate thickness to diagnose subclinical atherosclerosis, we also observed a higher risk of atherosclerosis in people with HIV, as shown in the red bars here, across all the younger age groups. And the differences between HIV positive and negative people are actually greater in the younger population. Stroke is also a common cause of cardiovascular disease, And similar to myocardial infarction, various studies in the last decade did show a higher risk of stroke in people living with HIV. So, why do people living with HIV have higher risk of cardiovascular diseases? The underlying mechanisms are due to the chronic infection per se, the use of antiretroviral drugs, and also other lifestyle factors. So this diagram here shows the different mechanisms of the increased risk of cardiovascular disease in people living with HIV. In various studies, we have seen that HIV infection, despite being suppressed with antiretroviral therapy, did induce a state of chronic inflammation and chronic immune activation in people with this chronic infection. People with HIV infection also suffers from microbial translocation, which is also a cause of chronic inflammation. And these patients might also have other concomitant infections, again, increasing the risk of chronic inflammation and immune activation. And all these would increase the risk of atherosclerosis. And it is also well documented that various antiretroviral drugs do increase the risk of myocardial infarction or the risk factors predisposing to cardiovascular diseases. For example, dyslipidemia, insulin resistance, and also weight gain. And in different cohorts around the world, people with HIV also have different lifestyle factors than the uninfected population. For example, higher risk of smoking, alcohol intake, and hepatitis C infection because of intravenous drug use. So all these factors also increase the risk of cardiovascular disease. There are multiple studies looking at the relationship between antiretroviral drug classes and also the risk of cardiovascular disease. The DAT cohort is one of these studies. So in these cohort studies, we do see a longer duration of antiretroviral therapy is associated with increased risk of myocardial infarction. In particular, this is seen in patients on protease inhibitor. As for the NRTIs from the DAT cohort, diadenosine and abacavir, with recent use of these two NRTIs, were observed to be associated with increased risk of myocardial infarction as well. In terms of clinical management, of course, we would like to reduce the risk in our patients. If we look at the different guidelines from around the world, most of the guidelines do recommend regular screening of cardiovascular risk in people living with HIV. Of course, from different parts of the world, they might have their own risk estimation equations to assess the cardiovascular risk. So some of the examples include the pooled cohort assessing the atherosclerotic cardiovascular disease risk, or the DAT cohort, which include HIV-related factors, for example, the use of antiretroviral drugs. But mind you, many of these estimation tools might underestimate the risk of cardiovascular disease in people living with HIV. In Hong Kong, we have performed a study recently to look at the prevalence of coronary artery disease in our population of patients living with HIV infection. We do CT coronary angiogram for our patients with at least one risk factor of cardiovascular disease. So if you look at the different cardiovascular risk assessment tools, you can see that the performance actually was poor to fair for the prediction of coronary atherosclerosis or obstructive coronary artery disease. Therefore, better tools are actually much needed for people with HIV infection. In terms of clinical management, to reduce the risk of cardiovascular disease, we should optimize the control of the various risk factors. Lifestyle modification is very important. We encourage our patients to stop smoking and also use alcohol in moderation. In terms of diet, multiple studies have shown that a greater intake of vegetables, fruits, and healthy sources of proteins, whole grains, etc., would be good to our hearts. And at the same time, we should limit simple sugars and red meat. We should also encourage regular physical activity in our patients to improve their cardiovascular fitness. In various guidelines for treating HIV infection, it is recommended to screen for the risk factors for cardiovascular disease, and this would include risk factors such as the cholesterol profile, the sugar level, etc. In various guidelines, LDL cholesterol is the main parameter that we should monitor because this would guide our decision whether lipid-lowering therapy, most often statins, are indicated in our patients. In terms of the decision for using statin, this would be fairly similar to non-infected individuals. However, when we are starting statin in our patients, we have to be aware of the drug-drug interactions between statin and various classes of antiretroviral drugs. In terms of diabetes, the clinical management is fairly similar in patients without HIV infection. Of course, there are some points we should take into consideration. For example, it is quite common to use HbA1c to monitor or even diagnose diabetes. However, we should be aware that HbA1c levels can be affected by various classes of antiretroviral drugs. Therefore, we might have to use fasting glucose or other methods to monitor the glycemic control in people with diabetes. So this is an example from the American Heart Association guideline to assess cardiovascular risk using the pooled cohort equation, and also in people who are determined to have high risk of cardiovascular disease, how lifestyle modification is advised, and also what types of dosage of lipid-lowering drugs should be initiated. In terms of the antiretroviral regimen, as mentioned before, some of the drugs do carry a higher risk of cardiovascular disease. For example, in the European guidelines, they do recommend switching these drugs to drugs which cause less metabolic disturbances and are associated with lower cardiovascular disease risk. Next, we will look at bone health in people living with HIV. Again, it is well observed that people with HIV do have higher risk of osteoporosis and also fractures. For example, in this recent meta-analysis, we do see a higher risk of fracture, fragility fracture, and hip fracture in people living with HIV, and the bone mineral density are significantly lower than uninfected controls. And it is also observed that for patients who are started on antiretroviral drugs, their bone mineral density will decrease with time. In most studies, we do observe the greatest decline in the first year of starting antiretroviral drugs at both the hip and also the lumbar spine, as shown in the table here. In the first year, the decline was greatest, while it's sort of stabilized after the first year. And of course, different antiretroviral drugs might have different impact on the change of bone mineral density over time. For example, TDF is known to have increased risk of greater decline of bone mineral density, And in this meta-analysis, it's shown that people on abacavir and also TAF do have a significantly slower decline in BMD over time. This study from China looked at the changes in BMD and also the bone turnover markers within the first year of starting antiretroviral treatment. And again, you can see that for most of the bone markers, the greatest decline or change was observed in the first year after initiation of drugs. And after that, the changes are more or less static. As an uninfected population, we do have to be aware of the risk factors for low BMD, osteoporosis, and fractures in our patients with HIV infection. So of course, people who are older, female, with risk factors for hypogonadism, with a low BMI, vitamin deficiency, steroid exposure, and also these lifestyle factors would increase the risk of osteoporosis and fractures. Interestingly, traditionally, an increase in body weight is believed to be a protective factor for bone mineral density. However, in uninfected population, we do observe obesity is a risk factor for osteoporosis in some studies. In our patients in Hong Kong, we did look at the association of obesity and bone mineral density. And it is observed that after adjusting for other confounding factors, for example, age and body weight, central obesity was a statistically significant factor associated with low bone mineral density in our patients with HIV infection, especially at the femoral neck. In terms of clinical management, as for cardiovascular disease, it is important that we do regular screening for osteoporosis for our patients. In the US, for example, the RDSA guideline, they do recommend DEXA screening for osteoporosis for all patients above the age of 50 or in postmenopausal women. In some other countries, for example, the European guidelines, they do recommend assessing the fracture risk using the FRAX score in people aged 40 years and above. And DEXA should be considered in people who have a high FRAX score risk or other risk factors for osteoporosis, as mentioned above. So this is the FRAX score, which can be accessed online. So this is a tool to calculate the risk of fracture in people, in different populations of people. So they do have country-specific references in terms of their BMD and their risk of fractures. So if we input all these variables into the website, the FRAX score or the risk of hip fracture and major fractures can be calculated. So mind you, one of the variables that we have to insert is the presence of any secondary osteoporosis. And in many guidelines, it is recommended to consider HIV as one of the causes of secondary osteoporosis. So of course, we would use DEXA scan to diagnose osteoporosis. And in postmenopausal women and men aged 50 years and above, we would define osteoporosis using a T-score of BMD less than minus 2.5. And in younger populations, we would use the Z score. In all patients, we do encourage sufficient dietary intake of calcium and also vitamin D. And in people who are diagnosed to have osteopenia, osteoporosis, or with history of fragility fracture, we should exclude secondary causes. And at the same time, we have to consider intervention with vitamin D, calcium supplementation, or even pharmacological treatment. Exercise would also be important to improve the bone mineral density. For patients diagnosed to have osteopenia, osteoporosis on DEXA scan, vitamin D level should be monitored or checked. And if vitamin D deficiency is diagnosed, then vitamin D should be replaced and with DEXA repeated to monitor response. Although there was limited data of the use of bisphosphonates in people living with HIV, previous studies did show the effectiveness of using bisphosphonates to improve BMD in people with HIV. And after initiation of treatment, we would recommend follow-up DEXA around 1 to 2 years later to monitor the response to therapy. In patients who are taking TDF, one clinical question is whether switching off TDF would be sufficient in improving BMD and whether additional bisphosphonate is actually indicated. So this recent study looked at 2 different groups of people on TDF and diagnosed to have osteoporosis and to see the impact of either just switching off TDF and also switching off TDF plus the addition of bisphosphonate. In both groups of patients, we do see significant improvement in BMD. However, there was more improvement in the group who switched off TDF plus adding on bisphosphonate. Therefore, adding bisphosphonate together with changing the antiretroviral drugs might have better impact on improving BMD. So this is a summary of the algorithm to screen and also manage people with osteoporosis. So it is very important to screen for osteoporosis, either with a risk score to calculate the risk of fracture, and or if DEXA scan is available, to do DEXA scan in older people living with HIV. And if osteopenia or osteoporosis is diagnosed, we should check their vitamin D level, exclude secondary causes of osteoporosis. And if they do have osteopenia or osteoporosis, we should consider both non-pharmacological and pharmacological intervention. So we do expect a continual rise in proportion of older adults among people living with HIV in both high and low income countries. Screening and management of these comorbidities is now an integral part of clinical management of people with HIV. Regular screening of cardiovascular risk and osteoporosis is recommended for older adults with HIV infection. Lifestyle modification is very important in prevention and management of these comorbidities. And in certain populations, we might have to consider switching the antiretroviral drugs and consider pharmacological therapy for the management of these comorbidities. So thank you very much.